It's a pleasure to be here. It's an honor to be here. I had the pleasure of coming last year to Medellin, and it's an honor to come back to your beautiful country. So thank you for the invitation. My practice in Austin Heart in Austin, Texas, has been using CardioMEMS for about 2.5 years now. We've become, in that time, very familiar with the technology, very comfortable. And today, my hope is to convey my learning curve, where we started 2.5 years ago, somewhat, in the dark, and having just read about how the device works and what medications do, but then really following through and creating a workflow. So my hope today is to convey to you kind of my stumbling blocks and how we've kind of gotten better from there. So who are we? Austin Heart is a large practice in Austin, Texas. We're 44 cardiologists plus about 20 nurse practitioners. And we work in a private practice model up until 2010. So we were privately owned. We were our own bosses. Around 2010, we aligned with a hospital system, and that's been happening a lot in the States, where private practice is kind of a thing of the past, and we're now hospital employees. So we became aligned with Hospital Corporation of America in 2010. And our practice functions similar to most large practices. It's a hub-and-spoke model, where the hub, or the central practice, is the heart hospital. It's a 60-bed hospital where we do our high-risk PCI, our bypass, our structural heart, like TAVR, Lariat, mitral clip, Watchman. And the remaining clinics span about 100 to 120 kilometers north, south, east, and west. And anyone that's sick comes to the heart hospital. That's kind of how our practice works. In our CHF practice, I'm the medical director of heart failure for the practice. We have 3 physicians. We have 3 nurse practitioners, and we have 2 nurses and 2 dedicated research nurses. Some exciting things on the horizon. We'll be starting soon a DT VAD program, a destination therapy VAD program. Right now, we don't do transplant. We refer the transplant patients out to another center in Austin. So in terms of the CardioMEMS launch, we launched CardioMEMS a few months after the FDA approval. The FDA approval was May of 2014. And that was based on, as Dr. Peroni pointed out, the Champion Heart Failure study that showed a significant reduction in heart failure hospitalizations, namely almost a third out 18 months. So after that robust data was published, the FDA approval happened in May of 2014. Our first implant was in 2014 in September. And since our first implant, we've done almost 50 implants. I don't implant them. I actually have interventional cardiologists to implant them for me. So I am a medical cardiologist. I don't do swans, and I don't implant the CardioMEMS. But I have 8 interventionalists who do that and do it well. So our team for CardioMEMS is, in 2014, part of our growth curve was myself and my nurse, just 2 people. And I'll talk a little bit about kind of the workflow and what happened in 2014 and where we are now. But currently, our team includes myself, 2 nurse practitioners, my 2 nurses, and my 2 research nurses to really involve ourselves in the care of these patients. And why, from 1 patient in 2014 to only about 50 patients now? This is a technology that's new, and I think if you don't have the infrastructure and the workflow, it can get overwhelming very quickly. So it's important that once you have this, that you start slow. And so the reason we have 47 patients, and we were only doing about an implant every couple of weeks, is because we wanted to make sure if we're doing it, we do it right. Ultimately, the implants will become quicker, and we'll have a much larger patient population. And we developed this coinage term called MEMS Monday, where on Mondays we review the CardioMEMS data. I wanted to share with you the first patient. So our first patient who is alive and well, 2.5 years out of implant, his name is Mr. I'll just use the initials, Mr. RW. He is a typical Texan. His BMI is about 36, so he's moderately obese. Likes his barbecue, doesn't like to follow doctor's direction. I'm sure none of your patients are like this, right? So he had 3 hospitalizations for heart failure to my hospital, to the heart hospital, in summer of 2014. And when someone comes to your institution numerous times under your care as a heart failure specialist, it's kind of embarrassing, right? You almost think it's a quality issue. What am I doing wrong? What did I miss? What did I not do the first time? So he received MEMS in September. He was our first patient, one of the first in the country and the first in Texas to get CardioMEMS. And since then, you can see what's happened. And so this is kind of a busy slide, but it shows that with time, so if time here is on the x-axis and PA pressures are on the y-axis, you're seeing PA pressures trend all over the place. And this is typical of every CHF patient you and I see. So what we're doing as a response to PA pressures, What we're doing as a response to the PA pressures is changing medications. So the MEMS device, as Dr. Peroni pointed out, gives you PA pressures, but itself doesn't change any hemodynamics. It doesn't change the inotropy, the chronotropy of the heart. That is all changed by medical therapy. So as the Champion Heart Failure trial showed, the most frequent medication change was diuretic therapy. That is what I see in my clinical practice. Now, we have novel therapies, not really novel. We have other medications we can use with this device in, because I don't know if I would ever empirically start a patient on nitrates without having some other metric to say no angina, so why use a nitrate? These patients, I'm actually using veno and vasodilators aggressively to lower their pressures, lower preload, lower afterload, and it works. If you look here, around early 2015, I started using nitrates in him, so isosorbide, hydralazine. I increased the dose. If you look subtly, I know it's a busy slide, he actually had a nice drop in his PA pressures. He was actually doing great, probably the best PA pressures he had. But of course, he likes his barbecue and he likes his water. So it went right back up. And so the thing that's worked the most effectively on him is diuretics. Unfortunately, it does come at the expense of kidney dysfunction, but that is the conundrum of heart failure. So the workflow initially in 2014, when the device first implanted in Mr. W, this is what we did. My nurse would call him Monday morning, ask him, Mr. W, how are you feeling? What's your weight? What medications are you on? Are you watching your salt? Are you watching the telemanagement questionnaire that all your heart failure clinics do, right? And that's time intensive. Maybe not for the practitioner, but the nurses. I'm sure if the nurses here, you know that those patients like to talk. And those patients are not succinct. And so they'll keep you on the phone telling you about their dog and their upcoming travels and their heart failure. 15 minutes later, my nurse would be finished and would have to go to the second patient. So it's a big time sink for her. 2014, 15 minutes, my nurse was spending that much time per patient on the initial intake. Then she would go to the website, merlin.net, where the CardioMEMS pressures live, and would print them out. So that printout per patient would take maybe, say, 30 seconds or so. That's pretty quick. Then that 16-minute time sink she had already spent, then she would bring me a stack of sheets and allow me to review the PA pressures, the 4 points every day, PA systolic, mean, diastolic heart rate, the 4 numbers you get. So I'd get 28 points over the last week that I would then review. I'd open up my electronic health record. We use Epic. So I'd have Epic open, a sheet of papers here, and then that's where I would start to make the changes. The changes, you can't overthink them. Really, you're looking at kidney function, medications, what changes you made last week, and then you think ahead to say, where do I want these pressures to be? And we'll go over the goal pressures in just a moment. It shouldn't take really more than 3 to 5 minutes. It's not, this is not high-octane science here. This is, how can I use vasodilators and diuretics to lower these PA pressures? But the fascinating thing for me, of course, when it first went in, is anywhere you have internet connection, you can look at the PA pressures. So, of course, as a man of technology, I had him on my phone. And so I would be looking at my PA pressures when my daughter would be at her dance recital. I'd be looking at PA pressures. It's fascinating to see what your patients are doing. Does that really help? No, not really. But it really is, it's interesting to see that. So I would be spending initially about 5 to 10 minutes myself initially per week to look at these PA pressures and give feedback to my nurse, sometimes even calling the patients myself. Then my nurse would then enact the changes I wanted, increase torsemide, decrease metolazone, increase hydralazine. To enact those changes would take her an additional 5 minutes to do that. So almost half an hour per patient per week, and that's, any new technology, no matter how good, it's a lot of time per patient per week, right? So there's got to be a more efficient way to do this, and that's kind of the initial workflow that why we started slow. And again, a tip to myself really is don't obsess on the daily numbers. Of course, you can set parameters to say, I want an alert, I want an email if the PA pressures exceed 55 on this patient. But below that, you won't get an alert. So I would encourage all of you who will partake in this, don't look at the numbers on a daily basis if they're well within the reference range, because it's a time sink, though it's interesting. So you almost wonder, as Dr. Peroni pointed out in a couple of slides, if we have telemanagement, and which we've done for decades and will continue to do because I don't think we'll ever dismiss that, does it really work? And if we have an indwelling device, we have a SWAN essentially without the output and index, do symptoms really matter? And I mean, I would give you the analogy where this question is going is when you go to the ICU and you have a patient with a SWAN, are you really going in to ask the patient, how do you feel? No, you're not. You're at the computer You're looking at the hemodynamics, you're looking at the eyes and nose, you're looking at kidney function. You make an adjustment, then you go in and you do a brief physical exam and saying, I'll see you tomorrow, or I'll see you in the afternoon. So you're really not asking the patient who has a SWAN how they're feeling. You just look to see if they're effectively diuresing, their kidney function's stable, their hemodynamics are okay, and you continue to manage them. So physical exam, I'm not suggesting it's unnecessary, but do you really care how they feel? You're really going based on PA pressures. So just based on the data Dr. Peroni showed that, again, looking at these large trials for when your nurses call and say, how do you feel, what do you weigh, what medications are you taking, how we try to connect with patients, maybe not physically, but at least by phone, it really doesn't reduce hard endpoints. Impact on heart failure hospitalizations? None. Looking at these almost 9,000 patients in this meta-analysis, no significant change in heart failure hospitalizations. It's kind of humbling to say, well, what is telemanagement missing? It's missing hemodynamics. And that is really where the crux of CardioMEMS comes in. So what have we done since then in the last 2.5 years? Rather than the initial phone call that my nurse made to spend 15 minutes to probably not help the patient's care or her time, she doesn't do that anymore. She just prints out the numbers from Merlin.net, puts that on my desk. That time takes her maybe 15 to 20 seconds. I then review, and again, I've gotten a lot more efficient, and I've actually taught my nurse practitioners, I have 2 of them, what we want to do, and so they help me as well. And those changes to make those assessments takes us about 3 to 4 minutes per week. And the nurse to enact those changes, it's now much more streamlined, where it takes her maybe 3 minutes. I wrote 0 there, and the reason I wrote 0 minutes is Merlin.net has a feature that actually can call your patient. If you have a stable PA pressure, my nurse can go to Merlin.net, and I'm not sure which button to hit, but she can hit a button. The phone call goes to the patient saying, no changes, you're stable. And it's a great time save. So the patients get communicated. My nurse doesn't have to waste time. We can continue to move along efficiently. So again, what is the time interval here for all this? It's about maybe, say, 5, 6, 7 minutes. A lot better than half an hour. So we're doing a lot more. We're going a lot more efficiently. So now we can, enjoy other things like enjoying your beautiful coffee. So and spend all of the time we need to drink the coffee. My hope ultimately is to have Merlin.net integrate with my electronic health record. So I've gotten on some conference calls where perhaps Merlin.net can feed the data directly, push it into my electronic health record, comes as a result. I can then convey the result. Some of the patients in Texas are very computer savvy. So in Austin, some patients love the internet. They can email us, and there's a patient portal in our electronic health record where they can ask me questions. I can send them results. We can maybe communicate this all electronically. So that would be a great, efficient way of doing this. We're not there yet, but that's my hope. So again, helpful tips in terms of what do I want when I have a CardioMEMS patient, and where am I looking to go? Goal PA pressures are always a systolic of 35 or less, a mean of 25 or less, and a diastolic of 20 or less. And that is the ultimate goal. You're looking to make medication changes to get those pressures. And no longer is a lack of symptoms acceptable to say, I'm not going to make changes. Ultimately, you may not get to these numbers. And ultimately, you may say, I may have to acquiesce to a PA mean of 30 or 35 because I cannot get them any lower, either because of hypotension or kidney dysfunction. But that is the goal. You want to get them there. And medication changes is the new norm. So we make medication changes in standard practice. We make many more medication changes with this. And that is how patients stay out of the hospital. And again, you can set parameters on Merlin.net to say, for Mrs. Perez, I want her PA mean to be no more than 35. I can't get it to 25, so no more than 35. If it's above 35, I want an email. And then you'll get an email if you do that, and provided she sends a transmission. Medications, that's really how the magic happens, right? So diuretics are the most common. I believe in Champion HF, it was around 85 to 90% of the medication changes were diuretics. Diuretic class changes can happen as well. So if one diuretic isn't working, you can change from furosemide to torsemide to bumetanide. I mean, you can change loop diuretics. Why do we do that? Because there's bioavailability changes. We use furosemide very commonly, but it's actually the least bioavailable. Maybe bumetanide or torsemide may be better. Maybe there's an expense change. But, and we can sometimes make those changes without asking the patients, how do you feel? And again, the whole issue here is we're not asking symptoms. Symptoms are important. But if the patients are not symptomatic and their pressures are rising, you better make a medication changes. Otherwise, you know the path that that's going to go. And also then using veno and vasodilators, using novel therapies like Entresto, using Corlinor or Ivabradine. I do have several patients who have reduced EF heart failure on sacubitril and valsartan, or LCZ696. And incredible, one patient was in the hospital. I gave her first dose. Her PA mean dropped by 10 points just on sacubitril. So, and ivradibine, I haven't widespread used this medication in my practice. I do have one patient with cardiomems to see her heart rate come down 20 points on Corlinor, which is interesting. Lab frequency with patients with cardiomems, you check the labs however frequently you need to. There's no innate buy-in to say I need to check labs weekly, monthly. Really, it's when I make diuretic changes or RAS access medication changes is when I start to use, or when I start to check labs more frequently. Otherwise, when I see these class 3 patients every 3 to 6 months, that's really when I get their labs. Telemanagement, I can still do it on request. So my nurses don't not do telemanagement. They'll always do telemanagement. But I don't have them do it regularly. I only do this when I'm confused and I really want to see if they have some other confounder going on. Sometimes we haven't seen these patients in 6 months. So we just want to make sure that we touch base with them some way. But I only do this on request. This is not something that we do weekly, monthly, or 3 monthly at all. Clinic visits has been a paradigm shift. So these patients who have class 3, patients who are the frequent flyers, you were seeing them in the hospital and in your clinic weekly or monthly, right? You maybe had a company at home, maybe a nurse to go to the house, give them diuretics at home. Very intensive managed patients. Some of these patients who have cardiomems now, who are now a year and 2 years out, we actually don't see them that often at all. And some of them have gotten complacent to forget they had heart failure. This has been especially helpful for those patients who live far away from the clinic. So if your site is here in Bogotá, I'm sure all your patients aren't coming from downtown. They're coming from the periphery, in north, south, east, and west. So I have patients coming from 150 kilometers away. That's not a short distance to make a round trip to come see me. And I'm not saying it's not worth it, but not easy. If I could actually check their PA pressures and then occasionally talk to them on the phone, it saves them the trip. And it provides the same care, if not better care. And the frequency of checks, again, just to let you know, again, a weekly check is sufficient. A daily check, not needed, as interesting as it is. This is a brief case, actually, one of the patients in the Champion heart failure trial. I showed this case to show you that diuretics can change, diuretic classes can change, and on account of diuretic class changes, I'm sorry, not class, medication can change, you can improve PA pressures and really not have to rely on symptoms. This is a patient who had, in 2009, had their cardiomems put in with a PA mean of in the 30s, systolic in the 40s, and a diastolic in the 20s. And like almost every patient who gets cardiomems, as soon as they walk out of the hospital, their pressures go up because life happened, right? They're eating what they want to eat, they're drinking what they want to drink. So this patient almost doubled his pressures within a span of a couple days. Diuretic changes were made. So he was initially on furosemide. His furosemide was increased further, and then his loop diuretic was changed from furosemide to torsemide on account of thought that this may be a stronger, maybe a more bioavailable medication. Torsemide was then increased, and then extra torsemide was given. Finally, his pressures came down. All the while, his weight did not change. He was very thin. His weight did not change very much. All the while, his symptoms didn't change very much. So no significant weight change. As Dr. Pennoni suggested, weights, really the delta weight in these patients who decompensate is not that much. Symptoms, of course, if we untreated this, he would have been symptomatic and he would have ended up in the hospital. But just a brief example to show diuretic changes, improve PA pressures, avoid a hospitalization. So far we've done almost 50 implants, 47 implants. We have 2 arms. We have an FDA-approved commercial arm. These are patients that have been implanted since September of 2014, and we call them the commercial implants. We also have patients in a clinical trial. It's not really a trial. It's more of a post-approval study, and it's to see really the real-world experience of these patients who have cardiomems. So these 2 cohorts aren't treated any differently, and they're both under the same kind of watchful care. We also have 4 patients in a CardioMEM CRT study. Patients who have CRT, a biventricular defibrillator, or a pacemaker, how are they optimized? I think probably suboptimally at this point, no pun intended, where they go to the echo lab and they have mitral inflow data looked at. Mitral inflow as a surrogate for cardiac output. And I think I'm an echo guy, and I'm sure those of you who read echoes out there know that it's a pretty murky data set where you could put that pulse wave Doppler anywhere in mitral inflow and really get a significantly different change. So using the CardioMEMS device, what if we were to use PA pressures as a better estimate of CardioMEMS, of CRT optimization. So we've actually done 4 patients this way, and I'll be glad to show you an example. For future research, we actually next year will be involving ourselves in a diabetic medication. It's of the category SGLT2 inhibitors, a medication that seems to be causing glucoseuria as part of its mechanism of action to lower pressures and actually improve hemodynamics. And we'll use CardioMEMS in that cohort next year. Just a brief example of the CRT patient. Here's a patient of mine who actually had the CardioMEMS multi-point pacing, or the quadripolar lead, quadripolar LV lead, whose baseline PA pressures before we started the optimization study was almost 80/30, so astronomically high, a mean of 51. And after we used the quick opt algorithm, which basically is a 90-second change of vectors with the 4 points in the LV wire to see what is the best vector, how do we optimize this patient's CRT device, and we lowered their PA pressures without a medication change, without a diuretic, by 5 points. So not robust. I mean, there's still, it went from astronomically high to less astronomically high, but still improvement. Improvement is improvement. Who is the ideal patient for CardioMEMS? So patient selection is crucial. In addition to developing the infrastructure in your office, choosing the right patient is absolutely, is probably one of the most important things. And the reason I say it is because if you choose the wrong patient, your patients won't do well. If you choose the right patients, those patients can do very well. The typical patient is your class 3, can't walk a block, can't walk a flight of stairs, frequent flyer, coming to the hospital over and over and over again. But not just frequent flyer, but this is my opinion here. This is not, again, FDA guidelines. They have to have mostly LV failure more than RV failure. So pulmonary edema, a lot more than if they have gut edema or even dependent edema. They have to be reasonably compliant. None of my patients are 100% compliant, as I'm sure none of your patients are 100% compliant. But at least they're easy to communicate with, and they'll receive a phone call. They'll do what I ask them to do. They may not eat the right foods. They may not drink the right amount of fluid, but they'll at least make medication changes. They'll tweak their compliance when I can ask them to do that. And also important is reasonable kidney function. Stage 3 kidney dysfunction, or maybe better. Once you've hit stage 4 and stage 5 and you're diuretic resistant, you give 200 milligrams of torsemide in a day and you're making maybe a liter of urine, that's a patient who may not do well with CardioMEMS. Not because the device won't be helpful for the pressures, but what can you do with that data? They're going down a different path. They may need dialysis. They may need something else. So people to maybe consider avoiding, and this is all based, every single patient that I've showed here is actually a patient that we've had that didn't do well. So people to consider avoiding implanting, class 4. Those patients who are symptomatic at rest, they're cachectic. They have an audible S3, no matter how aggressively you diurese them. RV failure. Why is RV failure tough? I mean, not RV failure in addition to LV failure, but if it's exclusively RV failure, you get no data for RV failure from CardioMEMS. That's a neck vein exam. That's JVP, right? Though JVP is not as sensitive to predict CHF exacerbations, it's still better than PA pressures would be for this cohort. Severe noncompliance, I call this the personality disorder patient. They won't receive a phone call. They won't do what you ask them to do. Then why would you give them this device? We've had one of those patients, and unfortunately we found out after the fact. So it's important to do a kind of a good screen initially to make sure this patient has a good support structure. They have a cell phone or they have a landline. They actually answer it, and they actually do what you ask them to do. And those patients whose kidneys are so far gone in dysfunction, stage 4, stage 5, verging on dialysis, we actually have had 2 patients out of our 47 that have gone on to dialysis. One patient is, we've transferred care to Houston to maybe consider a heart-kidney transplant. So it's not to say that those patients were incorrectly selected. It happens, and I'm sure many patients with the cardiorenal physiology that these patients have will go on to have worsening kidney function, but do take pause if you think that these patients are not diuretic sensitive and they have advanced kidney dysfunction. So on the learning curve, implant number 2, this was a patient who I received the phone call after the implant. And I've quickly learned I want to receive the phone call before the implant. If they want me to manage the device, I want to see the patient ahead of time. So this is one of my favorite EP doctors, electrophysiologist, who said, hey, Kunjan, I've got a great patient for you for CardioMEMS. I'm going to put it in this afternoon, and then can you come see her this afternoon? I said, sure. So he put the CardioMEMS device in. Initial numbers are here. PA systolic of 53, diastolic of 33, a mean of 41. She was a non-ischemic 81-year-old woman. Oops, sorry. Non-ischemic cardiomyopathy, EF of 15%. Her implant was a little bit after our first implant for our first patient. Her dry BNP was above 4,000, and her cardiac output at implant was 3. When I met her, after learning all this, she was cachectic, she had bitemporal wasting, she was a class 4. And unfortunately, I didn't know that ahead of time. This was my EP doctor who spends his time in the EP lab, curing AFib and putting in pacemakers. It's not to say that he wasn't well-intentioned or right-spirited, but unfortunately, a month after this implant, despite medication changes, CardioMEMS or medical therapy won't change this. When you have pump failure and you have bitemporal wasting, you're a class 4. Unless you're a VAD or a transplant candidate, these patients don't do well, and she passed away. Just to exemplify again that patient selection is crucial. Class 4 patients don't do well. Here's a patient who ended up having mostly RV failure that I didn't recognize ahead of time. Mr. G lives about 100 kilometers east of Austin. He would come to the hospital very frequently. Preceding CardioMEMS, which was implanted the summer of 2015, at least 4 hospitalizations in the preceding 12 months. And the CardioMEMS went in, and his PA numbers were not that bad. A PA systolic of 47, a diastolic of 23, a mean of 33. And I want you to appreciate, with time, his pressures actually have gotten better, right? So his pressures have trended down with many, many ebbs and flows for which we use medical therapy. Since the device implanted, he actually had 2 rehospitalizations for CHF. And it was very confusing, so I had him recathed and reswanned. His CVP was, during one of his swans, his CVP was 20, and his wedge was 20. He had a wedge to CVP ratio of 1 to 1. And for those of you who knows what that means, that's pretty much, that shows that RV is shot. Why didn't I know that on echo? Because he's morbidly obese. His BMI is 45. To echo him, even to TE him to look at his RV is almost impossible. But his RV looked maybe mildly dysfunctional by echo. By swan parameters, his RV was not functioning well. And unfortunately, with his rehospitalizations and his reaccumulation of fluid, he's gone on to hospice. And the challenge with him has been mostly RV failure. So I show this example to show that despite him, about a year ago, during a rehospitalization for CHF, having a PA systolic of 31, a diastolic of 9, and a mean of 19, in the hospital with a CVP of 20, this was not the most helpful device for him either. Here's an example of a patient in whom the device has been exceptionally helpful. Mrs. LR was a gal, 60 years young, African-American, who came to me as a second opinion. She was admitted to an outside hospital 19 times for heart failure, 12 hospitalizations and 7 ER visits. So she was at her wit's end. She was depressed. She didn't know anything but heart failure, admissions, hospital food. She was not home. She had no quality of life. Her EF was about 35 to 40%. She was an ischemic. She had bypass surgery around the time of a heart attack 9 years ago, and was admitted so many times where she lost all IV access. So she actually had an indwelling IV catheter to draw labs and give medication. So it's called a Groshong, and just was absolutely miserable. We were ready to actually do CardioMEMS in her late in 2014, but she developed sepsis from this indwelling catheter. She had the indwelling catheter because she was in the hospital so much. She was in the hospital so much because her heart failure was being mismanaged. So 19 admissions, Groshong catheter, sepsis as a result. The device was removed. She received IV antibiotics. She improved from that perspective. She received her CardioMEMS implant a few months later in March of 15. Here her hemodynamics, her PA systolic was 60, her mean was 40, her diastolic was 30. And her medications at baseline upon implant were pretty good medical therapy, carvedilol, so beta blocker, ACE inhibitor, mineralocorticoid inhibitor, nitrate, digoxin, cholesterol medications, Plavix, aspirin. And so after 19 ER admissions and hospitalizations, unfortunately, post-implant, she's had numerous. But for about a year, up until around February, she was actually managed as an outpatient. All these medication changes were all in my clinic. But right around here, February of 2016, so just about 10 months ago, she started getting rehospitalized again. And since that time, 4 additional rehospitalizations. Was the device malfunctioning? No. The device called it every time. The pressures would rise. I would be unable to treat them. With all the changes I would make, she'd end up in the hospital. Another typical Texan, BMI 41, very difficult to image. I thought I heard a subtle murmur, so I actually did a TE. Turned out she had severe eccentric MR. And it was not load-dependent MR. I would diurese her very aggressively. I'd re-TE her. Her MR was still severe. So many of our patients get severe MR as a load-dependent phenomenon, but when you diurese them, their MR gets maybe moderate, maybe mild. She had severe MR even in a dry state. So she just about 2 months ago ended up getting a mitral valve repair. And because she had an RV pacemaker with dysynchrony and an EF of 35 to 40%, we actually gave her an LV epicardial lead. So she has a CRT device and a mitral valve repair, and she's doing okay so far. Another fascinating case, Mrs. LB is a sweet woman, about a fourth generation, we call them Texicans. She's from Mexico, but fourth generation, so she's Texican. She has preserved EF heart failure. Her EF is actually hyperdynamic at 75%. She's had 3 heart failure hospitalizations before CardioMEMS, and her heart failure is probably one of the more challenging forms. Those of you who practice heart failure and know diastolic heart failure from HOCM heart failure is really hard because their hemodynamic window is very, very narrow, where if they're wet, they may develop heart failure, but their hemodynamics for HOCM may be more favored. If they're dry, they may feel better, but their hemodynamics for HOCM may be worse. So a dry state, more obstruction; a wet state, less obstruction. Very challenging. She did not have any overt HOCM issues in terms of symptoms, syncope, anything like that, initially. And she was moderately obese. She had these medical issues. She was on good medical therapy. And after CardioMEMS, and again, her implant data initially is here, a PA mean of 38, a systolic of 60, reasonable cardiac output and index. And she had astronomically high PA pressures. As soon as she left the lab, her PA pressures would occasionally be as high as 100. And we figured this was a combination of noncompliance and morbid obesity. And I'm showing you many morbidly obese patients. I live in Texas. That's the way it is, unfortunately. So we made a collective decision to say, you've tried diet, you've tried exercise, and your BMI is not improving. And this really was what appeared to us to be life-threatening morbid obesity with pressures that are just astronomically high. She ended up getting gastric bypass. So she got gastric bypass about 8 months ago. She lost a precipitous amount of weight, which was a fantastic thing. If you see here, her PA pressures trended down. Unfortunately, her HOCM physiology worsened. So she started now developing syncope, hypotension, volume depletion. So we went from having her on high doses of diuretics and medical therapy to on no medical therapy, no diuretics, and now using salt tablets. So she's on salt tablets and unrestricted fluid restrictions. So her management was challenging. I thought this was an interesting case to show you. Another example to say that, as I'm sure you work with some cardiologists that feel this way, there are some very reputable cardiologists around the world, and they think they do an amazing job, and I think I do a nice job, and my colleagues think they do a nice job. One of the more reputable cardiologists I work with in Austin was the primary cardiologist for this nice woman from Belize who looks African-American and speaks the most beautiful Spanish, who had an ischemic myopathy and EF of 25%, 4 hospitalizations to him for heart failure. Again, so rehospitalized. He would take care of her. And he called me scratching his head saying, Kunjan, I don't know what's going on with her. I diuresed her to a dry weight. She's actually not morbidly obese. She actually had a BMI of 24, so she was thin. And so you could look at her neck veins. You could actually check labs. You could do a reasonable physical exam. Yet 4 hospitalizations for heart failure. So CardioMEMS goes in. We discussed this ahead of time. I determined she's reasonably compliant. She has good support, good functioning kidneys, no significant RV dysfunction. She is a solid class 3. She's had 0 admissions since, thanks to the medication changes that we've made. My last example I want to show you is a phenomenon that is uncommon with CardioMEMS patients, but it happens, and it can create confusion, and it's called sensor drift. So this is Mrs. FH. She was hospitalized or in the ER every month for CHF or anxiety or both. And because she had severe pulmonary hypertension, COPD, diastolic CHF, and severe anxiety, it was impossible to know what's what. So she was being admitted all the time. Her BNP was always several hundred, so the ER doctors would always admit her. Very frustrating to her, very frustrating to me. Her CardioMEMS goes in around a little less than 2 years ago, and since that time, her heart failure hospitalizations massively improved. We, again, did the same thing we normally do, which is manage it with diuretic therapy. On account of noncompliance, she was readmitted. Oops. She was readmitted here and put on a LASIK strip. It turns out she was noncompliant with her medications. She was noncompliant with her diet. And closer to now, she actually then developed heart failure again about a year ago. And yet her PA pressures, I know it's hard to kind of make out what these numbers are here, are very low. Her PA pressures were well below 35, 25, and 20. And it didn't make sense. So when it doesn't make sense, always re-SWAN. SWANs are still the gold standard. And when we re-SWAN, her PA mean by CardioMEMS or her PA mean by SWAN were off by 15 points. And that's a phenomenon called sensor drift. So we recalibrated the device, and it's now spot on, and she has not been back in the hospital since. And that is what I have for you. Thank you.